sorry for the delay. My name is Dr. Jason. I'll be the moderator from today. I am from the National Cancer Society, NCSM. I work as the operations lead and medical officer there. This series today is our SKD series, where we talk about cancer every month of the cancer. And December is no exception. We're going to talk about the cancer of the month, which is skin cancer, right? And NCSM, the non-profit organized NGO. So if you have any questions later from this whole cancer talk or even this talk about skin cancer, please leave it down in the comment section below. During the Q&A, we'll get our consultant dermatologist, Dr. Teh, to help answer these questions as well. And please just stay on board, stay with us, and thank you all for your continued support. So now, to continue this, the topic today we'll be talking about is shining lights on skin cancer. Our consultant dermatologist who will be sharing today is Dr. Teh Yeon Chiat. She is a board-certified dermatologist from UKM with a focus on common skin conditions like eczema, psoriasis, acne, rosacea, hives, pigmentary disorder, alopecia, skin infections, contact dermatitis, skin cancer, and drug allergies. She's experienced in various dermatological procedures, including cryotherapy, intralesional steroid injections, skin biopsies, curettage, electrocautery, and laser therapy. Dr. Teh is also well-versed in skin allergy testing and patch testing. She's an active member of the Dermatological Society of Malaysia, DSM, and Academy of Medicine Malaysia, AMM. Demonstrating her commitment to the field of dermatology, Dr. Teh is dedicated to providing her patients with personalized, high-quality care for their skin-related concerns. She's working in Sunway Damansara Center, Sunway Specialist Center, Damansara, Selangor, and she looks very youthful. She's very passionate. We had a quick talk earlier, and I can see that she's very prepared and very ready to share her knowledge and expertise today. Without further ado, Dr. Teh, take it away.
Thank you, Jason, for the kind introduction. Thank you to Dr. Teh and NCSM for the invitation. So good morning, everyone. Today I will be giving a talk, Shining Lights on Skin Cancer. Just give me a moment. So this is the overview of my presentation. First, I will talk about epidemiology of the skin cancer globally and Malaysia, followed by the common types of the skin cancer, such as basal cell carcinoma, squamous cell carcinoma, malignant melanoma, then role of primary care in skin cancer and prevention. Of course, skin cancer, we cannot end the skin cancer talk without sun exposure advice. So skin cancer is divided into melanoma and non-melanoma skin cancer. Melanoma accounts for 22% of skin cancer diagnosis, whereas non-melanoma skin cancer accounts for about other 78%. Melanoma, the incidence rate is 3.1, slightly lower than the non-melanoma type. Among the non-melanoma type, basal cell carcinoma is the most commonly diagnosed skin cancer. So the epidemiology of skin cancer is actually one of the highest global incidence of any form of skin cancer. In fact, it's ranked 17th most common form of cancer worldwide. Recently, over the late years, both melanoma and non-melanoma skin cancer are uprising trend, but the mortality is getting lower, preferably due to the higher incidence rate of early reporting. So we can see that Australia has the highest incidence rate for both melanoma and non-melanoma skin cancer. This one is likely due to their location, geographical location, and their skin type. What about Malaysia? Our skin cancer incidence rate in Malaysia is ranging from 2.3 to 3.0 per 100,000 population. It's higher in men compared to women. Among our local population, Chinese ethnicity have the higher incidence rates of 4.5 per 100,000 population. BCC being the commonest skin cancer, which is also shown in this local data from a tertiary hospital, Kuala Lumpur. We can see the percentage of all the skin cancer detected is 31.9% contributed by BCC. So I will talk about basal cell carcinoma, squamous cell carcinoma, and melanoma. Each I will be talking about the common types, the risk factor, and then followed by a brief staging and the diagnosis, followed by brief management. So basal cell carcinoma is very common, locally invasive, and usually they are slow growing. They are a keratinocyte cancer, and usually they arise from the basal layer of epidermis, hence the name of basal cell carcinoma. If you can see from the photo of the right lower corner, is a rodent ulcer as a roll-out border. Yeah, this is quite classic. There are intrinsic and environment risk factors for BCC. Intrinsic factors include age more than 60 years old, being a man itself, skin type 1, fair skin phenotype. If you have a positive family history of skin cancer, irrespective of which type, Or if you have genetic syndrome such as xeroderma pigmentosum, Gorlin, albinism, all these genetic syndrome, they are more photosensitive. Environmental risk factor, also known as modifier factor, include UVR exposure, radiation therapy, patient who is on long-term immunosuppression, patient who has been exposed to chemical carcinogenic arsenic, patient who has been given topical nitrogen mustard. This topical nitrogen mustard actually we use it to treat mycosis fungoides, or even if you have a thermal scarring burn before, all these actually contribute to BCC. So there are 5 common subtypes of basal cell carcinoma: nodular, superficial, pigmented, morphiform, fibroepithelioma of Pinker's tumor. So if this is the commonest type, which is nodular BCC. They usually present as a papule or nodule, more commonly localized at the head and neck area because of the sun exposure. If a rodent ulcer, most of the time they are translucent. We can see some blood vessel, row border, and in the central there will be an erosion crater. Sometimes they have central necrosis. This is superficial BCC, where you can see erythematous patch. Usually they are quite well defined. They resemble eczema, but eczema usually they are not well defined, and eczema are itchy compared to superficial BCC. This kind of BCC is more commonly located at the trunk area. Another subtype of BCC is pigmented BCC. This is a subtype with increased melanization. That's why they have a darker pigmentation. If you later I will talk about dermoscope, which we can see some blood vessel if you go nearer. Also, patients have roll out border and erosion at the center. This is a quite aggressive form of BCC, which is a morphiform or sclerosing BCC. From the name itself, you can tell that it actually resembles a scar or a small lesion of morphia, which the skin look a bit atrophy. And usually they are a bit ivory white appearance. They will be lighter skin color than your surrounding skin color. This is another type of common BCC, fibroepithelioma of Pinker's tumor. Patient can present as a small pink papule or nodule, and usually this is common at the lower back. You can see the vessel is quite clearly. This is different from our normal skin tag. Normal skin tag usually at the fold area, and then the skin tag won't have so much vessel telangiectasia seen. So when we suspect a BCC, the diagnosis we need to do skin biopsy. It can be So by doing the skin biopsy, either we do incisional, excisional, or even punch biopsy as shown in the right side. It's a very simple method. So after we do this biopsy, we can get accurate histopathological features. So after we diagnose the BCC, we need to ask ourselves, how do we want to manage this patient with BCC? So it depends on whether the patient have a primary tumor or is a recurrent tumor. If it's a primary, it depends on whether is it aggressive or non-aggressive tumor and the location. Basically, the approach is guided by the anatomic location and histologic features. If it's not aggressive primary tumor, we can do excision or even electrocautery deletion. If it's aggressive tumor, we need to excise it fully with clear margin or even Mohs micrographic surgery. However, if patient at the high-risk area, we advise to proceed to Mohs microsurgery. Recurrent cancer, we prefer to go Mohs micrographic surgery to ensure complete clearance. The gold standard treatment is removal of tumor with clear surgical margin. So standard excision, when we compare with non-excisional technique, this offers the advantage of histologic evaluation. However, areas of margin involvement still can be missed. The cure rate for standard excisional surgery are actually inferior to Mohs micrographic surgery in cases of aggressive cancer like primary morphiform, recurrent BCC, or when the tumor is located in the high-risk anatomic site. So what is Mohs microsurgery? Mohs microsurgery, or MMS in short, is a precise method of treating skin cancer that will result in highest cure rate with maximal tissue conservation, cosmetic, and function. Just imagine if the patient have a skin cancer at the ala region, which is at the nose area or even near the eye. We wouldn't want to have too much of the margin unnecessarily to preserve maximum tissue. So in fact, by this study by Rowe, Carroll, and Day, the rate of recurrence if you do MMS for primary CC is only 1% compared to standard excision. So thus, this Mohs microsurgery micrographic surgery have been a treatment of choice for all these high-risk cases. So just now I have been talking about high-risk cases. One thing, the most important thing that we need to know is when we see a lesion, at which area that we consider this is a high-risk lesion. So if you look at the photo of the picture of the face here, those shaded in blue area are the high-risk area. If over the head and neck, it will be at the central face, eyelid, eyebrow, nose, chin, periauricular skin, or even the temple area, genital area, hands and feet. These are all high-risk area. So for BCC, when do we consider non-surgical treatment? Non-surgical treatment, we will use it for metastatic BCC or when there is locally advanced BCC. Locally advanced BCC means the BCC that is unable to be treated with surgery or radiation without significant morbidity. So for this kind of patient, we can use FDA-approved therapy, which is a hedgehog inhibitor pathway SMO inhibitor, such as vismodegib or sonidegib, or even we can consider platinum-based chemotherapy. This one works well for metastatic cancer or locally advanced BCC. So how is the cause and prognosis of BCC? For BCC, actually the prognosis is excellent with appropriate treatment. The control rate as high as 99% have been achieved by MMS. The risk of developed second primary BCC ranges from 36 to 50%. This one, it can be a recurrent or it can be a incomplete clearance of margin. However, there is a small risk of increased risk of melanoma for patients with history of BCC. As we said that BCC have excellent prognosis, the rate of metastasis also very low. It only range from 0.0028% to 0.55%. It's only less than 1%. If you have a metastatic disease, poor prognosis, the mean survival of 8 to 10 months only from the time of diagnosis. BCC is the commonest diagnosed skin cancer in our setting also, or in our clinical setting. Next, I hope I'm not confusing. So next we'll move to squamous cell carcinoma. Squamous cell carcinoma actually is the second most common skin cancer after basal cell carcinoma. In immunocompetent white individual, it's very common, like our Caucasian, is in the Caucasian country. And the most common skin cancer in immunosuppressed organ transplantation recipients worldwide. This is because they have been on a lot of immunosuppressive therapy, so they have more skin cancer. SCC development in the skin is considered a multi-step process because they usually develop from a pre-invasive lesion or in situ tumor, include actinic keratosis and Bowen disease. They are pre-cancerous, pre-invasive lesion. So it's also important for us to detect when the patient presented to us with either one of these. HPV infection, serotype 16 and 18 also have risk of developing SCC. So what are the risk factors for squamous cell carcinoma? As usual, cumulative sun exposure. If you have very frequent sunburn until you feel the skin is painful, more than 5 episodes during childhood, your risk is already higher. If you have history of exposure to chemical carcinogen long-term, arsenic usually at the C area, tobacco, or even coal tar therapy, you are also at risk of this. Genetic syndrome, as again, like BCC, you are very sensitive to sun. Patient who is immunosuppressed, either you have transplant before, or if you have HIV. Chronic ulcer, burn scar, when you damage the cell, you are also at risk of squamous cell carcinoma. So this chart actually summarizes the risk factor that I said just now. UV light, genetic predisposition, skin damage, immunosuppression, carcinogens, skin immune system, all these will cause DNA damage and it progress to SCC. So how do squamous cell carcinoma in the cutaneous present? In fact, they can present on any cutaneous surface, including the head and neck, trunk, extremities, even anogenital area without exposure to sun, periangular skin. It is most commonly found in fair-skinned individuals. If it's in fair-skinned individuals, their site most frequently exposed to the sun compared to non-fair-skinned individuals. In UV-exposed skin, usually it develops on a background of actinic keratosis or Bowen disease. In this photo, you can see this patient, they have this background photo of this is a sun damaged skin. You can see the pigmentation. The white color hyperkeratotic lesion are actually actinic keratosis. If you have seen this kind of patient, when you touch it, it feels very rough and actually is quite sharp in terms of the sensation. So this is not yet is invasive, invasive lesion. This one we need to treat it at this stage so that we don't progress to invasive squamous cell carcinoma. Another disease will be Bowen disease, one of the cutaneous squamous cell carcinoma in situ. It grows slowly, enlarging over the course of years, and usually they are asymptomatic. If you can see this, it's erythematous, well-demarcated border. It usually have scaly patches or plaque. Again, they are not itchy most of the time. They can be located in the sun-exposed area most of the time. Head and neck and extremities. So if you have seen this kind of lesion over this area, which doesn't respond to the early treatment, sometimes we might think it's a squamous, sometimes we might think it's eczema first. If it doesn't respond, it doesn't change anything, then we need to consider a possibility of Bowen disease. Next, we move on to this erythroplasia of Curette. This is another squamous cell carcinoma in situ involving the penis. Usually they presented with well-defined velvety red plaque. If you can see, let's see from this photo, the border is very well defined. And usually this kind of patient, they don't have any symptoms, means they are not painful or not itchy. Unless the erosion is deep, then they will have a secondary infection or they are painful. So if we did not catch them during carcinoma in situ, they might progress into invasive cutaneous squamous cell carcinoma. For this type, they are divided into well-differentiated lesion and poorly differentiated lesion. For well-differentiated lesion, usually they appear as an indurated or firm hyperkeratotic papules, plaque, or nodules. Whereas poorly differentiated lesion, they are usually fleshy, granulomatous, papule, or nodule. Poorly differentiated lesion have worse prognosis compared to well-differentiated. Another type commonly found will be the verrucous carcinoma. So verrucous carcinoma, they are well-defined, usually exophytic, and they presented like cauliflower-like growth. In fact, it looks like a large wart. This is a very rare variant. If by anatomic location, if in the oral cavity, they are called oral florid papillomatosis. This is another verrucous carcinoma of the oral mucosa, just that they changed the name. If it's at the anogenital area, it becomes a giant condyloma accunatum of Bosque-Lobenstein. Sometimes if you see a solitary growth at the lower lip with this kind of scaly lesion, which is non-painful, we have to strongly suspicious of squamous cell carcinoma. This lesion, they can present as nodule, ulcer, indurated, or even a white plaque. So high suspicious index is needed. Here is another type of common squamous cell carcinoma. Oral squamous cell carcinoma is presented as an ulcer, nodule, or indurated plaque in the oral cavity. So it's different from the usual ulcer that we see because they don't have a nodule or a raised lesion like here. Usually the common site will be floor of the mouth and lateral or ventral side of the tongue. Before they have this squamous cell carcinoma, they may arise in the site of pre-malignancy. For example, erythroplakia or leukoplakia area. So that's why when we see an erythroplakia or a leukoplakia patient, we need to follow up the patient to ensure that it's clearance or monitor for transformation. Next, I would like to highlight this margarine ulcer. Even though it's a rare type of cutaneous squamous cell carcinoma arising in a chronic wound or scar, but this one is sometimes we tend to miss because we have been treating the patient for a non-healing ulcer. We will be doing dressing, debridement, but actually patient is having a cancer, which it won't heal with our simple dressing. So this malignant transformation is usually slow. The latency time averagely is about 30 years, so it can grow very slow. The tumor may actually present as ulceration that fail to heal. If you have an ulcer that drag more than 6 weeks, then we advise for early referral for diagnosis confirmation. So after we are clear about this common type of squamous cell carcinoma, we need to know how do we stage. It's different from BCC. Usually it's local invasive. Squamous cell carcinoma is more invasive than basal cell carcinoma. We need to look for nodal involvement and look for area of metastasis. The common initial site of metastasis from lesion on the face and scalp include, if you have a nose and cheek lesion, you need to look for the submandibular nodes. If you have a lip and anterior mouth lesion, submental. Near the ear, it will be at the posterior auricular nodes. If it's a posterior scalp, occipital nodes might be swollen. Anterior scalp, forehead, temple, it might have an enlarged parotid nodes. So this is the area that we need to check sometimes if we see a lesion to make sure that we are not missing out a squamous cell carcinoma. So how do we classify? We are using this TMM staging from AJCC 2010. High-risk feature of squamous cell carcinoma include if the thickness is 2 mm, Clark's level means the depth of the invasion, more than 4, perineural invasion, primary sites being the lip or ear, or poorly or undifferentiated tumor. These are all high-risk feature. So when it's high-risk feature, staging of SCC will be lower. So how do we treat SCC? For this therapeutic algorithm, we can see we divide into low-risk and high-risk cutaneous squamous cell carcinoma. If it is low-risk, we can choose surgery, Mohs surgery, or radiotherapy. But surgery is always the mainstay. Mohs is not available in every center. In fact, has the Mohs surgery. Surgery, we need to have a positive clearing margin of ranging 4 to 6 mm. If you have a negative margin, means you just have to follow up the patient 6 monthly. If the patient, when you excise the lesion, you cannot have a clear margin, then you need to refer the patient for Mohs surgery or even radiotherapy. If it's high risk, we need to consider Mohs surgery if it's available early. If it's not, we just get a surgical margin of 6 mm. And again, if it's a positive margin after our excision, we need to consider subsequent therapy, either if we repeat surgery or radiotherapy. So we have been following European interdisciplinary guideline for the invasive squamous cell carcinoma as a management. This is just a recommendation for the primary cutaneous SCC, as what I have explained earlier. This is for the advanced SCC. The slight difference for advanced cutaneous squamous cell carcinoma is when they are locally advanced cutaneous squamous cell carcinoma or metastatic, they are not candidate for curative surgery. Thus, we have to treat them with a PD-1 antibody. EGFR inhibitor, cetuximab, it may be used for locally advanced and metastatic cutaneous squamous cell carcinoma. This kind of patient usually they have failed or to respond or unable to tolerate immunotherapy as stated earlier. Chemotherapy can be used for patients who fail to respond or intolerant to anti-PD-1 immunotherapy. So in short, majority of squamous cell carcinoma patients present with early stage disease and prognosis is excellent in majority of the cases. Most of them are readily treated and cured with surgery with clear margin. However, as we have diagnosed a SCC, patient might have increased risk of secondary NMC, non-melanoma skin cancer, compared to patient who has not have any squamous cell carcinoma before. Risk of developing metastasis from SCC is generally low, with a 5-year metastasis rate of 5%. And most of the time, the metastasis rate are predominantly nodal. So we are actually not much to be worried of. Okay. Before I proceed to another type, just excuse me for a moment. Just let me get some drink. We have covered basal cell carcinoma, squamous cell carcinoma. Next, we'll move on to malignant melanoma. Melanoma is a malignant tumor arising from melanocytic cells. Most frequent type is cutaneous. It also can develop at mucosa, uveal, and meningeal membrane because they share the same embryonic progression. 10% of this melanoma detected by lymph node metastasis. They are known as metastasis unknown primary. They are likely developed in lymph node for pre-existing nodal nevi. So this is another photo suggestive of melanoma, which is different from our normal nevus. You can tell from the heterogeneous color in terms of pigmentation. The border is irregular. Yeah? So risk factor of melanoma, is slightly more compared to previous BCC and squamous cell carcinoma. UV light exposure, again, is the utmost important exposure. Personal or family history of melanoma, it will 5 to 12% of all patients with melanoma has familial melanoma. So it's important for us to ask history of melanoma in patients who came to us. If they complain of abnormal mole, we need to know the family history. Fair skin, if you have a Fitzpatrick phototype of 1 and 2, which means you are very fair with blonde hair or brown hair, then you are at risk. Usually, Fitzpatrick phototype 1 and 2, they sunburn easily but not tan easily. Genetic, if you have a familial atypical mole melanoma syndrome, thus came the family history. If you have gene mutation, such as BRAF and RAF and c-KIT mutation, you are at risk of it. Again, xeroderma pigmentosa, where is an autosomal recessive disorder, you are very photosensitive, you have a lot of pigmentation, sun damage, you are at risk of melanoma. Congenital melanocytic nevi, most of us will have a melanocytic nevi, but it's abnormal if you have a lot. For adult, if you have more than 100 clinically appearing, typical appearing nevi, you are also at risk. If it's children, we take 50. If any patient complain to you the nevus look abnormal or atypical compared to other nevus, we also take it as a risk factor. If you have multiple dysplastic nevus is not the normal nevus or mole, shall I commonly say. This one, they look slightly different. So, but when we do the histopathology, it came as a dysplastic nevus. There are actually 2 times risk in the presence of the dysplastic nevus. If you have immunosuppression, also you're at risk. If you have history of radiation exposure for other treatment of other other cancer, you are also at risk. So there are total 6 groups of melanoma subtype. It includes superficial spreading melanoma, which contribute 41%, the commonest type. Nodular melanoma, 16%. Lentigo malignant melanoma is 2.7 to 14%. Acral lentiginous melanoma is range 5% only. The other 2 are less common, amelanotic melanoma and desmoplastic melanoma. Subtypes of melanoma are of no prognostic significance, unlike BCC. We'll move on to this superficial spreading melanoma. This is the most common subtype. It contributes 70% of all cutaneous melanoma. Usually it happens at intermittently sun-exposed area, most frequently lower extremity for women, upper back for men. Usually they were presented with irregular border and irregular pigmentation, but they may present subtly as a discrete focal area of darkening within a pre-existing nevus. This is the type that most commonly associated with pre-existing nevus. Patient will tell that the lesion actually patient noted that slowly changing over months to years. It can grow thicker, can grow broader, it can even change in color. This is the photo of example of superficial spreading melanoma. You can see this lesion is actually heterogeneous in color. They have brown, light brown, dark brown, and then the central actually is clear. This is actually a sign of regression. It's an active of the melanoma. So it's regression. This is a sign of melanoma. This is a hyperkeratotic. Patient will tell you that it's getting thicker. So if you see this kind of lesion, we have to be strongly suspicious. Yeah. Okay. Photo at the B, this photo B, is a melanoma arising from a normal nevus initially. You can see the central is started to become darker and it's actually scattered pigmentation like globule dot like that. So this is also abnormal. So again, I'll show the asymmetry border is a color varies. We can see at the picture A and E. Or even the C, D also is show very clearly different color. If you see this is something very sinister. What about nodular melanoma? It's the second most common melanoma subtype. It contributes about 30% of all melanoma. For this nodular melanoma, trunk is the most common site. Different from superficial spreading is a rapid evolution usually, often arising over several weeks to months. It won't drag up to years. It can begin it tend to begin de novo rather than arise in the pre-existing nevus. Means it will suddenly grow slowly, not slowly, sorry, it will suddenly grow, become a nodule on itself. Usually it appears as a uniformly dark blue-black or bluish-red lesion. Out of this nodular melanoma, 5% is amelanotic. Just bear in mind, sometimes early lesion, they are lack of asymmetry. In fact, they can have regular border and a uniform color. At this moment, we might actually think it's just a simple nevus, melanocytic nevus. And if you have, that's why any new nevus, we always advise the patient to monitor themselves to look for the sign of ABCDE, which I will explain later, to make sure that we detect the cancer early. So this is already an advanced. Amelanotic melanoma for the picture C is already ulcerated. D, it shows a pigmented nodular melanoma. You can see the satellite lesion at the 4 o'clock area. This is another photo of a nodular melanoma. We can see a dark pigmented papule. It's quite small. This is the dermoscope of the melanoma. You can see it's irregular border when we zoom in. They have these radial streaks of pigmentation. Okay. We'll move on to another type, which is the lentigo maligna or lentigo maligna melanoma. Lentigo maligna is a melanoma in situ. They grow radially, then it becomes invasive. It becomes a lentigo maligna melanoma. So this type of cancer, it constitutes 10 to 15% of all cutaneous melanoma and is most commonly found in older population. Usually this type of cancer is at the chronically sun-exposed area, face, cheeks, and nose. For the men, it can be at the neck, scalp, and ears because usually men, they have shorter hair compared to ladies. That's why it tends to happen here. Initially, lentigo maligna melanoma, they can be flat, and then slowly they enlarge. They can even look like our freckle, just that the shape and the color is different. And usually, again, it arises in the background of photo damage. Yeah? For this lentigo maligna melanoma, it actually related to cumulative sun exposure. The longer that you have been exposed to very intense sunburn, then the higher risk for you to get. This type of melanoma also higher recurrence rate with standard recommended margin, and when you have failed to completely excise the lesion, the recurrence rate very high. This is the least common associated with nevus because this is more in chronically sun-exposed area. This is another example in the background of we might think at one glance, you might think that it's just a sun damage like solar lentigo for an old man. But if you look clearly, you can see that at least 3 colors. Is a light brown, dark brown, and there is even some reddish at the center. If you look deeper, there is a telangiectasia seen at the 6 o'clock here. And the border is actually ill-defined. This one, ill-defined border is something that we are worried of. So here is another example of lentigo maligna melanoma, asymmetrical pigmentation lesion. Again, the border is irregular. And we can see the variation in terms of pigmentation, it varies too much. Usually the one that benign lesion that we saw, they will just have a homogeneous, brownish, well-defined patch like that for solar lentigo. And then there is some satellite lesion far away. And again, there is something called regression. The normal skin area, it becomes even slightly like atrophy-like. This is one of the signs of melanoma. This is the one that I wanted to show everybody because if you look at photo A, picture at the left upper corner, this is actually an early lentigo maligna. It presented as a light brown patch with a subtle asymmetric pigmentation, which sometimes we might think that this is just a sunspot, solar lentigo, or even early seborrheic keratosis. But when you go deeper by using dermoscope, we can see that this is abnormal. There's round pigmentation, and this vessel, this red color, all these are abnormal. If you compare A and B, picture A and picture C, picture A is, we might miss as because it's early, but picture C is more advanced stage. We can see again, the variation is the color is not homogeneous. They have more than 2 skin tones, and there is a central regression, which is the normal skin here. Another type of skin cancer that we tend to miss because we did not check is because it's at the acral site, acral lentiginous melanoma. This is most common form found in darker pigmented individuals. In fact, it's more common in Asia population. is older patient, usually middle age of onset, usually 65. Common site, sole, palm, and subungual. Interdigital space, toe web space is somewhere that we often miss. Advice, we can ask the patient to check for this. So again, you can see this is between the big toe and the second toe. Patient started with a small dot, and as it went undetected, it progressed further, then it become a nodule with some blood vessel and pigmentation. This is another sign. Acrolentiginous melanoma is at the plantar surface of the patient's foot. If you see a mole at the patient plantar surface of the feet, right, we need to examine clearly. If it's a very small, less than 6 mm, then we are okay. It's not suggestive of, it's one of the signs that not suggestive of malignancy. But if it's like bigger and then they have satellite lesion and the border is a bit weird, it's like irregular and the color like multiple shades, then we are worried. Another one, it will be subungual melanoma. Subungual melanoma is a variant of acrolentiginous melanoma. It usually arises from the nail matrix and is most commonly found on the great toe or thumb. So they can present with this melanonychia striata, which is the dark, irregularly pigmented longitudinal nail streak with or without nail dystrophy and nail plate elevation. You look at the photo at the right side, this one will be a long band of pigmentation. When it's more than 3 mm, it's broad. Color again, they have multiple shades of pigmentation. The brown is not homogeneous. Then it's suggestive of melanoma. Hutchinson sign is a pigmentation on the proximal nail fold. It's a bit, you can see a bit of black color, a bit of dark brown black color at the edge of proximal nail fold here, means because it's the invasion of the nail matrix. This is different from the longitudinal melanonychia that is commonly found in some of the patient that you have seen, which is a band is common. Next slide, I will talk about how do you consider malignancy whenever you see a pigmented nail lesion. Yeah? So if you have seen a pigmented nail lesion, when do you consider malignancy? We need to ask ourselves, do the patient have this 8 sign or clinical history? First, is it isolated on a single digit or multiple nail? Usually melanoma will be on a single digit. If it's a longitudinal melanonychia, which is a benign, it can happen in more than 1 digit. Patients tend to present to you when they are older, 4 to 6 decades, compared to longitudinal melanonychia, which is the benign lesion, will be younger. If you ask the patient might give you a history of abrupt pigmentation, which is a previously normal nail plate. Patient will just tell that the pigmentation comes just suddenly. Sometimes it can be acquired pigmentation of the thumb, index finger, or large toe. So we need to ask ourselves, why patients have this acquired pigmentation? Is it suddenly? Why patients suddenly have a pigmentation is abnormal. If the patient appears darker, larger, or blurred towards the nail matrix proximally, then this is also suggestive of something malignancy. If the patient tell you, doctor, I have this pigmented band after I injured my toe, oh, then you have to be cautious already. Because if the patient injured the toes after the, let's say if the patient hit the toe at the door, then they have a bruises. But after the subungual hematoma subsided, you rule out already it's not subungual hematoma, the melanonychia persists, then you have to be strongly suspicious of malignancy. Any individual with history of melanoma, if they presented to you with a pigmented nail lesion, the suspicious index should be very, very high. If the pigmentation nail band is associated with nail dystrophy or even absence of nail plate, again, this is another indicator of melanoma. From this photo, you can see a clearer Hutchinson sign. The pigmentation actually extending to the periungual skin. You can see at the top right corner of the nail plate, the dystrophy of the nail. So the black color pigmentation is actually at the corner here. Whenever the width of the band is more than 3 mm, then we are worried also. Okay. Next, we have to go to the clinical diagnosis of melanoma other than the nail pigmentation. So generally, we follow the rule of A, B, C, D, E. A stands for asymmetry, B stand for irregular border or notching border. C stand for color variegation. Diameter, usually if they are more than 6 millimeter for skin melanoma, or if the lesion is evolving. So as in the patient will give you a history of morphology changes of the lesion, or you detected it by photographic evidence. Of course, this is just a clinical diagnosis. The diagnosis confirmation of melanoma is still skin biopsy. This is a photographic, more clearer picture of ABCD. We can see asymmetry in terms of the size of the lesion. The border is irregular. The colors also vary, multiple shades of brown, black, and the diameter is more than 6 mm. The last one will be the evaluation. You can see the progression of the lesion from early lesion, it progressed to advanced stage. That's the reason that we need to detect it early before they progress. Yeah. When we have a malignant melanoma, we need to stage the patient different from BCC and squamous cell carcinoma. We can do sentinel lymph node biopsy because sometimes they have the melanoma, primary melanoma, they might not have clinically or radiologically active positive lymph node. This is the time that sentinel lymph node biopsy came in. So in fact, when this sentinel lymph node biopsy is the most important prognostic factor in the primary tumor with a breast flow thickness of more than 1 mm. Once you have lymph node, you consider this sentinel lymph node biopsy when it's stage 1B. Yeah? We can proceed with ultrasound of the regional lymph node in all primary melanoma stage 1B and higher. CT contrast, PET-CT, MRI brain, mutation testing, all the imaging are not indicated if it's a stage 1A and 2A if patient clinically asymptomatic. Serum LDH is a prognostic factor, same as the mutation testing or BRAF. Mutation testing or BRAF, it indicates the treatment of choice later in case if the patient develop into more advanced disease or metastasis. For melanoma, we follow the TMM system for classifying. As usual, it will be a T, N, and M. Okay, I won't go through this one by one. This is just the staging. I would like to bring your attention to this TNA staging for invasive cutaneous melanoma based on breast flow thickness or depth. Because the breast flow thickness, when we biopsy the melanoma, the depth of the invasion vertically actually determine the survival rate. If it's a stage 1 where the invasion is less than 1 mm, they have higher survival rate. Whereas when you have a deeper invasion, more than 4 mm, the survival rate only less than 50%. So what about clinical prognostic factor? For prognostic factor, if clinically, first thing we ask is gender and age. Women have better survival rates than men for this malignant melanoma. Older age group have worse prognosis, even with the overall survival rate also lower. Males with more than 60 years old have the highest mortality rate. If you have distant metastasis, this is the worst prognosis that patient can have. And the site of metastasis actually is important prognosis factor in the melanoma staging. Usually, if you have a visceral metastasis, you have a poorer prognosis. And again, if you have elevated serum LDH when you have the distant metastasis, also your prognosis is worse. This time, this serum LDH prognosis factor is irrespective of the site of metastatic disease. Yeah? For malignant melanoma, the prognosis is not as good as basal cell carcinoma and squamous cell carcinoma. It actually ranges from 30 to 75%, depends on the metastasis state. For example, if you have only satellite and in-transit metastasis, the survival rate is only 30 to 50%. But if you only have a lymph node micrometastasis, the survival rate will went up to 75%. If you have a clinically apparent lymph node or even metastasis, it dropped to about 50% or so. Distant metastasis is a poor prognosis. If a patient not keen for treatment or not suitable for treatment, the median survival, it will be only 6 to 9 months. So from this side that we can know that even though melanoma contribute about 5% of skin cancer, the skin cancer related death for malignant melanoma is the highest, about 80%. So for management of malignant melanoma, of course, we have to do, if it's a stage 1A, then we'll do a wide local excision. Of course, the margin will be very wide. Lymph node dissection, if it's a stage 3B or C and above. Radiotherapy, chemotherapy reserved for advanced metastatic cancer, melanoma. High-risk primary, we can actually add on an adjuvant therapy of interferon alpha. There are newest therapeutic option, which is the targeted therapy, BRAF and MEK inhibitor when you have the gene mutation. Immunotherapy such as CTLA-4 inhibitor and PD-1 inhibitor also being used when you have advanced cancer with this advanced metastatic cancer or inoperable melanoma. So this is the new therapeutic option that I was trying to tell just now, targeted therapy and immunotherapy. Targeted therapy, which is a BRAF or MEK inhibitor. BRAF inhibitor, we have a few choices. Mainly is a vemurafenib, dabrafenib, and corafenib. MEK inhibitor also is a TNIP type. Sometimes we use combination when it's a patient is not responsive to one, we can consider to add on another one. So for this BRAF or MEK inhibitor, they are a bit slow, but they have a longer lasting effect. So these are immunotherapy, which is an immune checkpoint inhibitor. Usually we use this when patient does not have a gene mutation compared to the BRAF and MEK inhibitor that I said just now. Programmed cell death protein anti-PD-1 inhibitor is the latest. In fact, now this PD-1 blockage as a monotherapy or combined with CTLA-4 blockade has been recommended for all patients with unresectable metastatic melanoma. Yeah? Okay. We have finished with these types of skin cancer, how they present, the risk factor, their prognosis, and a brief overview of their management. But I think main thing is we still need to know that how can we detect it earlier. There is something called dermoscopic examination that we dermatologists will use this dermoscopy. It's a skin surface microscopy, handheld and non-invasive. The sensitivity ranging from 60 to 100% by experienced hand. But this dermoscopic examination cannot replace our histological examination. It's very useful as an early screening or when patients have so many more, especially if you have a patient with skin phototype of skin type 1 and type 2, it'll be very useful because patient will be having a lot of pigmentation, whole body, face. So it's unlikely that we go and biopsy all the lesions. So this time, this dermoscopy will play a role. I will share about dermoscopy features of the malignancy. So this is the dermoscope feature of malignancy, mainly for basal cell carcinoma here. We can see emborizing vessels, ulceration, even leaf-like, maple leaf-like area, blue-gray globule. They can have a nest-like lesion, spoke wheel area. The white color is a regression that I said earlier. Yeah. So for example, this is how dermoscopy look like. Patient can have a large blue-gray ovoid nest by the dermoscopy. Blue-gray globule, we can see. In fact, we can see very different color. This is the blue-gray globule that I want to show. This is the leaf-like structure. If you use the dermoscope, we zoom in already, we can see the leaf-like structures. Spoke wheel structures. Okay. It's the projection. They start from the central darker, then the radial projection go upward. This is very abnormal. This is arborizing vessel. We can see the vessel coming out. Usual nevus wouldn't have this kind of vessels. Shallow ulceration, you can see patient have wounds shallow, which is not treated after you give topical antibiotic or dressing. If patient have this persistently, then we need to consider is a cancer. This is another type of melanoma. Scar-like depigmentation, you can see the central, the white color. These are all depigmentation. It's a regression features. Radial streaming at the edge of the pigmentation. Again, it's multiple color shade. Peripherally, you can see peripheral black dots and globules also. Okay, so we have finished the basal cell carcinoma, squamous cell melanoma, the types of the cancer. Dermoscopy is one of the tests that we do in our clinic setting. Actually, it's not a test, it's just our routine examination by using a dermoscopy to aid in terms of the diagnosis of all the atypical nevus or suspicious mole. Next, I will proceed to role of primary care, because for us, it's very important that we work hand in hand with our fellow colleague in the primary care. You have seen more patients than us, and then important thing is detection early. Early detection play a very important role. Thus, I will talk about role of primary care for skin cancer prevention. It's very challenging when we see a mole, because sometimes patient might be sharing with you, I have this mole since young. Why I have this mole lately? Why I got mole only when I'm older? Because some nevus, they actually can come later in life rather than all coming out one shot when you are a baby. So it's very challenging. But we still need to try our best to detect it early, because as I have presented earlier, earlier detection skin cancer actually it matters. Okay. However, even though early detection it matters, there is no worldwide evidence to suggest screening for skin cancer regularly. What we can do is we always ask the patient to monitor their own. If it's a nevus, it looks benign. If patient not keen for excision, we can always ask them to monitor. Come back if they have changes in the size, the color, even if it turn irritated, bleeding or ulcerate, then they can come. Other than the ABCD rules that I explained just now, there is a risk assessment tool that we can be used and in the primary care setting. So this is called weighted Glasgow 7-point checklist. They are divided into major features and minor features. If you have major features, it will have 2 point each, minor feature 1 point each. For major features, you have changes in size of the lesion. If patient, the nevus, so-called mole, have been getting bigger, changes in size, the pigmentation is irregular, or even the border is irregular. Anytime patient has any one of it, it will be 2 point. If patient have minor features, for example, it's inflamed, it looks irritated, it's red, itchy, or painful, any altered sensation, it looks abnormal, they will have 1 point. If it's a larger than other lesion, this one means, for example, if a patient have a lot of freckles, a lot of mole, at one glance, you look for the ugly duckling sign. This is what we do when we screen for a cancer in a patient. If they have a lot of mole, we look for the one that look abnormal, larger, ugly duckling sign. So if they have a larger than other lesion and more than 6 or 7, then it is 1 point. If patient have crusting of the lesion, they become ulcerated, also 1 point. When you combine these major and minor features, anytime they have more than 3, you need to refer to us for diagnosis, and then we can do the appropriate intervention. So it must be like Glasgow 7-point checklist. We have a point to suggestive of malignancy. Then what is the reassuring clinical features that suggest a benign skin lesion? Again, if it's a regular color, surface, and border, and it's less than 6, we are not that worried. If it's a growth over days, not weeks, then we are worried of pyogenic granuloma. This is a benign lesion. They grow rapidly. Usually it happens preceded by a trauma to the site. Patient will give you a history of trauma to the site, then they have this growth. And the lesion, it might be bleeding, a bit difficult to control bleeding. We will remove the thing by electrocautery usually, yeah? Okay. Or if the patient have a stuck-on appearance with keratotic plaque on the surface, this actually suggests a seborrheic keratosis. You can see from the photo, it's very well-defined margin. So it looks like a stuck-on appearance. Patient will tell that they feel like they would just want to like scratch it and remove it. So this is one of it. This is benign lesion. Dimpling. If bilateral pressure, if you see a lesion like this, so it's a border actually is quite defined, but it's red. When you see this lesion, you can start to just pressure on it, you pinch it. So if you pinch it, they have a dimpling, means this is a dermatofibroma. However, if you have this lesion, dermatofibroma, there is something called dermatofibroma protuberans sarcoma. So that time we are worried of cancer also, but most of the time, if they are longer progression, they are not expanding, then we are not worried. Dimpling sign suggestive of dermatofibroma. If you have a pigmented lesion in the child, the likelihood of a malignancy is less likely, unless the patient have a very large melanocytic levi, more than 20 cm, then you are worried. Okay. However, due to the variable appearance and difficulty in diagnosis melanoma, rule out features, this is only helpful, but it's not confirmation. Anytime that you think it's atypical or you think this is worry, we just do a biopsy to get our confirmation. Yeah. Okay. Prevention of skin cancer. So how do we prevent skin cancer? Just now I'll talk about this intrinsic factor and modifier environmental factor. We cannot change the intrinsic factor, your age, your skin type, your gene, you cannot change, but you can change the modifier factor. So the modifier factor most commonly that we can change is protection from sun exposure, which also is the most common cause of skin cancer. Treatment of precursor lesion early for squamous cell carcinoma, which is an actinic keratosis and Bowen disease, it play a role. And prevent transmission of HPV by vaccination also play a role. Again, modifier risk factor, alcohol consumption and smoking cessation is very important to prevent skin cancer. Let's say if you have a transplantation done before, you're on long-term immunosuppression, you have actinic keratosis a lot, we cannot remove it one by one, we can consider oral retinoid. Usually we use acitretin. It actually can inhibit the squamous cell carcinoma growth. It actually will reduce the development of cutaneous squamous cell tumor in high-risk population like the one that I said, transplantation patient. So we give this, the doses varies. So, I mean, the doses varies of acitretin, and we need to be careful when we give acitretin. It is only prescribed by the dermatologist for the chemo prevention. Then topical retinoid, if the patient not suitable for oral retinoid and the actinic keratosis not many, you can consider topical retinoid, either adapalene gel or tretinoid for the treatment. If you manage to treat the actinic keratosis, the chances of likelihood of them progress to squamous cell carcinoma will be lower. So what about sun exposure? 80% of skin cancer are considered preventable. Reduction in exposure to the main risk factor UV radiation will actually benefit the patient. So it will be very helpful if our primary care colleague can help to explain to the patient that we see risk and benefit of sun exposure to the patient. There is a study say that if you have this before 24-year-old, you have frequent sun exposure, frequent sunburn episode until you feel the skin is burning, you are much more higher risk. So sometimes prevention matters. The earlier you did the sun protection is better. So above 6-year-old, you could sometimes we advise the patient, the children 6-year-old, they can start using sun protection. Sun protection is the most effective preventive measures. Adequate sun exposure beginning in early childhood, like what I say, above 6. We have to start teaching our younger generation about sun protection earlier. It's just to protect them from skin cancer. So what do? We apply sunscreen repeatedly, SPF 30 to 50, at least 30 will be good. They can wear hat and protective clothing, especially if they are high risk, and avoiding sun during the hours of peak intensity. Usually it ranges from 11 to 2 o'clock in the noon is very bad. We live in Malaysia, our sun is very strong. Some of the smartwatch nowadays in the market, right, they can actually measure the UV exposure. If the UV index is 3 and above, then you need to really do some sun exposure. You need to put on the sunblock already, So this is another list that suggests we can give to the patient regarding sun exposure. Avoid the intense sunlight. Use the clothing. White brim hats are not the normal hat. Long sleeve garment. Avoid tanning, but tanning is not that popular among Southeast Asian country. It's more over at the Western country. Regular application of sunscreen, 2 hourly, advice. Outdoor workers should wear some protective clothing and also again apply the sunscreen 2 hourly. Patient at increased risk, which is a high risk, they have family history of cancer, they have transplantation done, they are immunosuppressed, they have gene predisposed to it, then they should be advised to practice regular skin self-examination. So when we tell them about skin self-examination, we can just explain to them again the ABCDE or even the weighted Glasgow scale point checklist that we said just now. So this is a very nice campaign that was done by the Australian Cancer Council in 1981. Slip, slop, slap, sit, and slide means we slip on a long sleeve protective garment. In fact, in Australia, some of the garment is actually protected from the sun. They call it UPF. Long sleeve and long sleeve UPF is different. Of course, long sleeve is better than nothing. But if you have buy the material with this UP protection, it's very good. Slop means you put on sunblock at least 30%, and it has to be repeatedly applied. Doesn't mean morning once, then you are done for the day. Slap on a hat, white brim hat. Seek for shade when it's intense sun peak hours. So we must look for the shading to cover ourselves. Slide on the sunglasses. You can protect the high-risk area, especially the periorbital region, the nose area, and the temple area. It will actually prevent wrinkle because you protect from the sun. So for my take-home message today, BCC is the commonest skin cancer type. It can be preventable by modifying the environmental factors, and sun protection is utmost important in skin cancer prevention. early referral play a very important role, which we need our help from our GP colleague here. Okay, thank you very much for the attention.
All right, thank you so much, Dr. Teh, for that wonderful experience sharing with us about skin cancers. I think I learned a lot. Thank you for sharing with us about BCC, SCC, as well as malignant melanoma. It's very much appreciated. Actually, just wanted to ask, you are now working in Sunway Specialist Center, Damansara. That's in Nexus, right?
Yes, it's in Nexus, Kota Damansara area.
Okay. No, because I passed by a few times, like, oh, okay, there's a Sunway hospital here as well. And I think there's ENT and Ophthalmology. That's quite amazing.
Yeah.
Yeah. And I think you've shared with it a lot, and I think a lot of take-home messages that I feel that are very relevant. Even for myself, if I have family or friends, I'm definitely going to send them your way. I can consider sending them your way because, in all honesty, the amount of knowledge you shared with us and the expertise was very impressive. I was very well presented. I definitely learned a lot, and I guess it's reassuring to know the prognosis is not so bad for BCC, SCC, right?
Yeah,
Malignant
it's not so bad
melanoma,
one.
but
Basically, we
malignant
need to detect
melanoma,
early.
yeah, so detect early. Can so there are a lot of questions actually that came in from different places. Let's go through them one by one. The first one is actually from Dr. Chew Bang. He's asking, is melanoma under the nail precancerous? Do you need to remove it, or how to remove? Basically, subungual melanoma. Is I think he's
If it's
probably
a
asking how.
subungual melanoma, means it's a cancer already. If it's a melanoma, it's cancer. So it depends on how deep is the invasion. Usually, if I see a pigmentation, which suggestive we are worried of melanoma, we actually lift up the nail cuticle, we just remove it, and then we biopsy it.
Oh, okay.
We remove the nail and we biopsy it, and then we see the depth, then we stage it. It is a melanoma, we need to treat it. Either we remove it, sometimes we cannot remove it, like we have to remove by dermatologist because the margin might not be able to clear because it's in the nail. So we need to refer to either to a plastic surgeon. So we make sure there is a clear margin, but we need to remove it because it's a cancer for sure, Dr. Chu.
Yeah.
Uh-huh.
Okay. I think that was very accurate or adequate to answer Dr. Chu Bang's question. So just if you remove that part of the nail bed, right? Sorry, just this is me asking today for clarification. If you remove that part of the nail with adequate depth as well as a clean margin, would that affect the nail bed pulp as well? So you won't have like
No, I need to clear
nail.
myself. You just imagine you lift up the nail, you don't have the nail
Okay.
plate anymore. The plate,
Yeah.
the nail, you don't have it
Correct.
anymore. You biopsy, you see how deep is the invasion of the carcinoma. If it's early stage, we go by the white excision. So once you excise it, you would no longer have a nail unit.
Okay. Interesting.
It won't grow back because you remove the whole nail unit.
Correct.
So it would be lucky if you can still maintain the nail. I mean, if it depends on the staging.
Okay. So yes. So definitely need to lah. All right.
Yes,
So
definitely we
actually,
need to remove it.
yeah, definitely need to remove. Correct. So thank you, Dr. Chu Bang, for asking that first question. He also has actually a follow-up question. Very interesting. Not too sure if Malaysians are doing this, or maybe just I katak di bawah terpurung. But is oral sex a cause for oral mucous membrane cancer, or rather, like oral melanoma or mucous
Yes,
membrane melanoma?
because HPV got a lot of serotype, type 16 and 18 associated with this varicose carcinoma. So it depends on whether when you have oral sex, is it contaminated with HPV? Did you carry the virus? Because as we know, HPV carries by the man side. That's why earlier start, they always vaccinated all the ladies, all the young girls below 16 years old in our national immunization program. So it's a risk if you have HPV, if you have this risk factor. But it's
Okay.
not a must for it to cause, but there is a risk.
So if got HPV, then it's a risk. If got no
Yes,
HPV, not
it's the
risk, but
HPE
you
itself.
wouldn't know lah.
Yes. The one we wouldn't know lah. It's a HPE only.
Can definitely. All right. We have a few more questions. We will ask them later. Actually, just a few more questions. Actually, from my side, I wanted to actually ask, why are women better prognosis than men? I saw that
Sorry.
it highlighted to me. Why are women having better prognosis than men for melanoma? Because it highlighted there. Women got better
Oh,
prognosis.
okay. So when we go through the study, they did not say much, but what I understand is women will tend to put on sunblock more regularly compared to men, and then men will go out to the sun more.
Okay. exposure. So it's
and
just
then
purely because of exposure.
yes, it's probably because of the exposure. This is because of when they do a cross section, they realize that men will have worse prognosis and they tend to have bad lesion. Again, it can be because the men tend to present later. Women, I have one pimple, I will start looking at it every day. So that it is a lot of modifier risk factor. Gender is not modifier. What I meant is the sun exposure. It's because of attitude of the patient itself.
Yeah. No, I guess men are very stubborn. Unfortunately or unfortunately. I don't speak for all men, but I mean in general from what I see. So actually, the next question from Dr. Padma, who's a GP, he's actually asking, are the oral sunscreens like HelioCare effective? Have you heard of HelioCare? This is the first time I'm actually hearing about it.
Yeah. So the oral sunscreen, HelioCare, actually they use this polypodium leucotomas extract. It's just a plant-based. It's an antioxidant. Because how do we age and how does the UV damage our cell is because by the oxidation. So we want to block this oxidation. HelioCare, their product is called polypodium leucotomas. So they will block the antioxidation, and it actually, for me personally, it worked because I use it also. But it doesn't mean that you do not need to apply topical sunblock if you are taking oral sunblock. It doesn't mean you take oral sunscreen is enough. You still have to apply two because this is just antioxidant. To Dr. Padma, they have strong, good study.
Yeah, so it's good. HelioCare also is good and it's quite effective as well. But at the same time, you still need it doesn't substitute sunscreen SPF 30, 50 or 100, but it's a good supplement and a good add-on, right? That's basically
yeah, it's a good supplement to add on. There are a lot of antioxidant supplement in the market now.
Okay, can. So you use HelioCare, so it feels effective.
But I'm not promoting the brand now, but
okay,
since it come
so
out.
disclaimer, we're not promoting HelioCare.
I mean, I cannot promote only HelioCare like that, but then since the question came out.
Yeah, correct. Since the question came out, correct. So actually for another doctor's family medicine specialist, if I'm not mistaken, he's actually asking, I think it's a very specific case, right? This is a very specific case. I think it's a case that he's seen. But basically, if it's a subungual hematoma, subungual melanoma has been removed, histopathology doesn't show any cancer, but suddenly after the nail excision, they find out there's a cancer now. What's the next step?
Histology does not show cancer.
But so
I think what Dr. meant is the melanonychia, the pigmentation, we remove. Okay, if we remove the subungual melanoma with a white margin clearance, no more cancer. If recur means it's a recurrence. So we can actually still repeat again a white local excision. Of course, you need to you can add on another therapy, like the targeted therapy, immunotherapy, if you keep on having recurrence. But of course, this is very individualized based. We need to know the staging first.
Okay. Right. Yeah. I think that adequately explains it. Dr. Suki, I hope that adequately explains it. So another one is from a Dr. Chu Beng. Again, he's asking, is nevus under the nail necessary to treat? Means if I see nevus under my nail, is it something I need to go and do a skin biopsy? Is it something I need to do a treatment for it or not?
Actually, we seldom have nevus under the nail. It's because of how we progress, our cell progress. Because the nail unit, they don't have the nevus usually. But I think what Dr. Chiu Beng meant is the pigmentation. If you have a pigmentation, like what I presented earlier, even though it's not a pigmentary whole band, but you have a nevus, like pigmented color, if it's suspicious, we always biopsy. Because something to grow below the nail is something that we need to be worried of. Even though if it's not a melanoma, it can be something else like glomus tumor or things like that, which it look like slight pigmentation. We need to biopsy.
Okay. So basically, if you see any like pigmentation under the nail, especially if it's suspicious, definitely just go for the biopsy. That will be the
yes. If it's suspicious, we always biopsy.
Okay. Can. So a few more questions from different places as well. So actually, someone is asking Dr. Teh, in your practice, what is the commonest presentation you see from your patients?
Honestly, BCC is still the common. Melanoma really rare. BCC, sadly, the one that I used to see, they came late. I have ulcerated BCC, which is quite big, things like that. Unless those patients that they are under our follow-up for something else, for example, they have phototherapy done, they have other skin diseases, which they are also on immunosuppression, then we notice that, because sometimes we notice that we look at the face, it looks weird to us, so we detect earlier. But those that came to us, the one that I have seen is quite late. They already have ulceration, big lesion, because it's slow growing, right, the BCC. So patient will keep it for years, sometimes 1 to 2 years, not only they come to you. But it's still treatable one, because BCC, they are usually locally invasive.
Okay, can. And do you see any pitfalls or you see any achievements you've seen from patients coming from primary care? Means like they went to a GP or they've got clinical center. Oh, okay.
They always
Can
refer
you show
one.
us again?
Atypical mole patient concern, when they refer to us, true enough, is also concerning for us. We do biopsy. Yes, it come out as a BCC, so we just remove it.
Okay.
So that's why I say is earlier when I was discussing all the case, I say we need to like appreciate the primary care in terms of the referral, because they see the most patient. So when it's referred earlier, we can actually remove it early. But sometimes it's the patient, when they come to you, is only when it's very late. The referral is fast, but the presentation, the first presenter itself is slow. So we need to educate the public about the sun protection and self-check mole.
I think skin cancer is not a very common thing that people talk about.
Because it's not common in Malaysia also.
Right.
Compared to other cancer.
Yeah, but like what you say is true. You can detect early. You might as well be aware, right? You just learn about it. You just check yourself.
Yes,
Any weird symptoms, see your dermatologist. I think it's a very straightforward thing.
Yes.
Then you saw the weighted Glasgow 7-point checklist is the best way for screening for primary care, correct?
It's quite easy. Yes. Other than the ABCD, other than the ABCDE rules and the naked eye examination, the weighted Glasgow scale is another checklist that you can use.
So let's say someone has a family history of skin cancer. Let's say, how often will you ask them to go see a doctor to do the weighted scale, the weighted Glasgow point? Like, it's like, let's say I got family history. Do I need to go for screening like every year, every 2 years, that kind of thing?
If you have a family history of skin cancer, I always teach the patient to do self-mole examination. So up until now, there is no worldwide recommendation. UK, they recommend that 6 monthly you can go for screening if you have previous cancer. So we actually follow our patients 6 monthly for follow-up, just to check through everything. And they are being taught on how to examine on their own, look for the ugly duckling. We call it ugly duck, means it looks abnormal compared to other mole. So if you say the patient with only family history but never have cancer itself, if they want to come to us check, we just check, but it's 6 monthly check usually. But if not, most of the time in Malaysia setting, we teach them when to come. If they have this ABCDE, or if they have all these changes, they will just drop by anytime.
All right, I think there's one more question from Dr. D. Dr. Saw Ong is asking: is hairy mole considered as a benign, just benign, a hairy mole?
Hairy mole itself, usually the one that we saw is the benign one, which is the big one with the hair sticking out like that. So, but it's not an indication that it is benign, because you can have abnormal pigmentation, which is a skin cancer with a hair also. Means even the hairy mole, it can progress to cancer. So I cannot say that hairy mole is benign.
Okay, understand. All right, Dr. So I hope that answered your question. Yeah. So we are. Oh, interesting. I think he sees a lot of dermatological cases. So question by question or word by word is seborrheic growth need to remove treatment? Word for word he asked. Is seborrheic growth need to remove treatment? Seborrheic.
Seborrheic growth, there is a skin lump called seborrheic keratosis, the one that I showed earlier for one of the benign one. Usually we remove it when it become itchy for patient keep on scratching, then it become irritated, or for cosmetic reason. Otherwise, seborrheic keratosis, the likelihood of it turn cancerous is very, very low.
Right. I think that was a very good answer. Thank you, Dr. Teh.
No problem.
So I don't think there's any more questions. I guess to recap, I guess your take-home message was very good already. About BCC, SCC, and as well as role of primary care. I think that's fantastic. Thank you so much, everyone, for attending this. And thank you, Dr. Dave from Sunway Specialist Center Damansara, for helping us or giving this information to all of us here. I think we all learned a lot. And the fact that there's so many questions, it's remarkable already.
Okay,
Right.
thank
Well,
you.
hey, Dr. Tay and everyone else, I hope you all have a fantastic Saturday and a weekend ahead. Merry Christmas, Happy New Year, and see you all soon.
Happy New
Bye.
Year. Bye bye.